missed it for the growth.
I have to tell you, we're recording. I have to tell you, Azjaah is a star. She has been fantastic, as you'll see in her.
I knew that. Thank you for reaffirming that. Thank you.
Thank you, Dr. Mingo.
Oh, Juliet, you remember Bob Perret? OBGYN with me.
Yeah, yeah.
Bob is here. He's
Hello.
here visiting with us. I'm trying to convince him to maybe do some GYN in the future for us.
You're going to recruit the entire crew of people.
All righty, so you're not going to see me much on the screen. I'm going to be over here standing up, walking around, but you should.
You have it pointed up?
Yes, I think.
I don't think it's going to show up on that.
Oh, it's not.
No,
Okay.
No.
Oh no.
I have a
it's not.
pointer for you, but it doesn't show up well on the.
Okay, and then this isn't changing it. Okay, so I have to do it.
Let
Here.
me see if I will.
Okay, that's fine.
And it's just, it works on the wall, but it won't work on that, I don't think. I have it. See, you
Oh,
can't see
okay.
it.
Oh, yeah, you can't see it. Okay,
You
that's
have to
fine.
use your finger, I think. Okay.
All righty, so
Recording?
it's
Good.
recording. We're going to get right into the case, and then as I go along, I'll reveal more information to you about what we're going to discuss today. So let's go ahead and get started. So case one, we have DM. It's a 61-year-old male with a past medical history of high blood pressure, arthritis, and hyperlipidemia, who presents with a complaint of losing weight despite eating more than usual. He states this has been occurring for the last 5 months, and he is becoming concerned. He denies cough, shortness of breath, hemoptysis, and chest pain. His surgical history consists of a partial gastrectomy, post-gunshot wound. He is currently an everyday smoker, half a pack per day for the last 20 to 30 years. He is living in a local homeless shelter. His other medical history is otherwise unremarkable for now. On this visit, his vitals, his height is 5'6", temperature 98.2, pulse 62 beats per minute, weight 98.6 pounds, respiratory rate 18, and a 61-year-old male with a BMI of 15.9. On his physical exam, the patient appeared hectic, and he was in acute distress, and he was very disheveled. His cardiac exam, regular, no S1, S2, no murmurs. Pulmonary exam, bronchi were noted in the right upper lobe. His left lobe was clear to auscultation, and no use of accessory muscles. His chest X-ray shows increase in apical cavitary lesion from prior X-ray. And as the arrow shows, sorry, I have to step in, you can see that there's a right apical lesion up here on the right.
There's one below it too.
Yes,
I'll lift this the same.
right here in the same area too.
Yeah.
So this brings us to our topic today, approach to pulmonary nodules. And I didn't introduce myself, I'm sorry, but you all know I'm Azjaah Rogers, a fourth-year medical student from the beautiful state.
Would you mind advancing the slides on the PowerPoint as well, like on the share screen?
Oh, I thought I was. It's not doing it correctly. What are you seeing right now, Nick?
I still see slide 1 and it's in like the non-presenter view.
Oh.
Sorry to interrupt your presentation.
No. Is that better?
It's still on 1 for me.
Wow.
Is that for everyone?
Sharing. Technical difficulties.
Why this is chirping. It wasn't chirping all morning now. It's chirping.
What are you seeing now, Nick?
Now I see the introduction slide, approach to pulmonary nodules.
Okay, perfect. So that means you missed the case, the slides of the case, but
Awesome. There we go. Yeah, I just
Okay.
couldn't see the X-ray. I could see the case slide, I just couldn't see the X-ray.
Okay.
Perfect. Thank you.
All right. So again, this is the apical lesion I was discussing where the arrow is pointing. All right, so our approach to pulmonary nodules. So just some brief information about pulmonary nodules. It's described as a lung nodule is defined as approximately rounded opacity, well-defined, measuring up to 3 centimeters in diameter. You can break that down further into the specific types of lung nodules. You can have solid nodules, which are most common, ground glass nodules, and part solid nodules. And on the screen, I have some images of what they look like. So a pure solid nodule is usually very dense and homogeneous. I'm not sure if this is for the crowd. And they usually obscure blood vessels and airways. Whereas a ground glass nodule, the name glass kind of tells what it is. You can see through the nodule and they don't obscure the blood vessels or airways. The most common ones are solid. So when we're discussing pulmonary nodules, the most important thing to decide is this pulmonary nodule malignant or is it benign?
Zoom users often attend meetings or webinars from their own homes. Bad hair days, barking dogs, shirtless toddlers, running
Alan's
things.
iPhone, can you
We've all
mute
been
for us, please?
In this video, we'll cover
Oh,
audio
no.
and video.
Alan's
basics.
iPhone.
Let's start with audio.
I don't know if I can mute them.
I hear you.
Can you mute your video for us, please?
Start the video, you said?
No, mute it. We can hear your background information.
Okay. All right, I just turned it off. Okay.
Okay. All right. So now let's talk about some differential diagnosis between malignant nodules and benign nodules. So one of the most common malignant nodules is primary lung cancer. It's adenocarcinoma. And then followed by squamous cell carcinoma and large cell carcinoma. Other malignant nodules, we can always think about metastatic cancers. So some of the most common metastatic cancers are melanomas, sarcomas. You can have breast cancer, kidney cancer, and testicular cancer that can also metastasize to the lungs.
Thyroid also very common.
Say that again?
Thyroid.
Oh, thyroid. Yes, definitely. And another one that's least common is carcinoid tumors, but those can also migrate to the lungs if they bypass the GI tract. A differential for some benign etiologies, the most common are infectious, and they're usually fungi. So histoplasmosis, coccidioides, and then mycobacteria, AKA tuberculosis. Some of the least common ones are abscess-forming nodules such as Staph aureus, and then we can also have some benign tumors such as hamartomas, which is just a mixed connective tissue disease. And the chart has a bunch of different other ones like amyloidosis, sarcoidosis, those can also cause pulmonary nodules. So with this patient, when this patient comes into you, what is the first thing that you should do? Of course, we should definitely do our history and physical exam, and we can also dive into some other clinical features based on what we see. So some of the most common risk factors for lung cancer, you have, of course, smoking. It's increased with greater age. It's more common in females. It's actually more common in males because they usually smoke more, but females can also, it can also appear in females. Also prior malignancy and sometimes asbestosis exposure. So depending on where you work, you can also increase the risk of pulmonary nodules. Some risk factors for non-cancerous lung nodules, the number one is immunocompromisation.
Secondhand smoke.
And secondhand smoke. That's a very big one. After we get our physical and our history and physical exam, what do you do next? Let's go ahead and move on to some imaging studies. The number one study for detecting lung nodules is a CT without contrast. I know a lot of people start off with an X-ray, which is not a bad idea, but the X-ray doesn't show the depth that we need to actually evaluate the nodule completely. So you definitely, if you get an X-ray as your first step, the next best step is a CT without contrast. Some other imaging studies that can be used outside of the X-ray, you can use a PET/CT scan of the whole body, and then you can also use a CT with IV contrast, but without is the preferred modality. And again, I will reiterate, if you do detect the lung nodule on chest X-ray, proceed to the next step to further evaluate, which would be the CT. So if you get the CT back, this is usually for radiologists. However, if you wanted to look at it yourself, these are some different categories that they normally look at when describing the lung nodule. So size, it matters a lot. If it's less than 5 millimeters, it's given us that it's less than a 1% chance of becoming malignant. If that nodule is anywhere between 5 to 9 millimeters, the percentage increases a little bit to 2 to 6%, then it increases further from 8 to 20, and then greater than 20, it's greater than a 50% chance of becoming malignant. Growth, that's another category. Fast growing, slow growing, or unchanged. If the growth is defined as an increase in size of greater than 2 millimeters. So a nodule that remains stable for 2 years or longer, on a chest radiograph is usually considered benign. You don't have to do any further workup. Following nodules with CT is now required to detect if there's any growth changes. Another feature you can look at is calcifications. These normally represent benign lesions, and these are commonly seen in tuberculosis, but it can also be seen with carcinoid tumors. You can look at whether the calcifications are central, diffuse, or lamellated. Oh, I'm sorry, lamellated. And other features we can also look at is the borders of the lung nodule and whether there is fat present. And those are usually benign. The fat present is usually a benign feature such as a lipoma. Okay, so if you do the CT scan and you see that the nodule is growing, what do you do after that? A pulmonary nodule that has clearly grown on serial imaging is most likely to be malignant, and the next step should be a lung biopsy. If the nodule is stable, we say a nodule is stable, it's been stable for greater than 24 months or 2 years, or a subsolid nodule that is stable for 5 years, then they don't usually warrant any further workup. Nodules with fat or calcifications, those are usually benign, such as granulomas, hamartomas, and tuberculosis, which is a different entity. But if it's a benign tumor, then there's usually no further workup for that either. The issue is when we get to the indeterminate nodules. We can't tell whether it's growing or whether it's stable. So those usually require either further CT imaging or a biopsy via transbronchial biopsy or endobronchial. Okay, so what do you do if the nodule is greater than 8 millimeters? As we talked about earlier, this increases, the greater the nodule size, it increases the risk for malignancy. So these usually warrant further workup. Patient with greater than 8 millimeters should definitely go forth with serial CT examinations or a biopsy. When you do serial CT examinations, it means that the nodule, once all of the workup has been done, it has been determined that the nodule has a low probability of converting to malignancy. So those you just follow up with CT. You would do it at 3 months, then again at 9 months, anywhere between 9 to 12 months, then again anywhere between 18 to 24 months. But if the nodule that was indeterminate has a high probability, anywhere from 5 to 65%, then you should go ahead and get the biopsy. Nodules that are less than 8 millimeters, they're usually followed with CT if they're between 6 to 8. If they're less than 6 millimeters, then there's no follow-up warranted. How do we biopsy these lung nodules? So there are 2 different options. You can do non-surgical biopsies, which are usually good for candidates that are not surgical candidates. So if they're older in age, if sometimes pregnancy, different conditions, depending on the patient, you may not want to surgically biopsy the lesion. So these are some non-surgical biopsy methods. You can do the bronchoscopic technique, which is what I talked about a little bit. You can sample it through the airway, and that's this picture over here. There's a forceps at the end. You can just grab a piece of the tissue once you put the scope through the airway. Then you can do the transthoracic needle biopsy, which is just directly going through the chest wall and taking a sample that way. You also have some surgical biopsy options, which is actually curative to the lung cancer if you can get the entire specimen. And that's called resection by video-assisted thoracic surgery. Follow-up. After we've done the whole entire workup,
This meeting is being recorded.
After we've gotten the whole entire workup, we got our physical, we got our history, we got our imaging, we also did some sampling. What do we do from there? CT surveillance. So this is important if those nodules were between that 6 to 8 or less than 8 millimeters range. You want to do CTs at least once a year if it's less than 6 centimeters. And if it's anywhere between 6 to 8, then we can also follow that 3 months, 6 to 9 months, 3 months, 9 to 12 months, 18 to 24 months. Then this chart looks very, very busy, but this is just breaking down everything that we already
about
talked
how
about.
you make your workforce productive, no matter where or how they want to work. This includes remote employees who work from home, Workspace One provides remote
I'd have to
employees
stop
with the
sharing the
tools they need to
screen,
be
mute
successful,
everybody.
starting from on.
Sorry, guys. Okay, so like I said, this chart seems very busy, but it breaks down everything that we talked about. At the top, it says it's asking, what do you do when the person comes in with a with the nodule that was not detected on CT? The next step is to go ahead and obtain a chest CT. And then if the nodules changed or unchanged, if the nodules unchanged, no further follow-up. If the nodule's growing, then of course we go to biopsy or resection because it's a higher likelihood of malignancy. If it's less than 6 millimeters, then we don't usually do much. We can follow up serially, but it's also dependent on the clinician and what they want to do with the patient. If it's 6 to 8 millimeters, again, reiterating chest CT at 6 to 12 months, then you can continue. If it persists, assess the likelihood again, and then as you get more information, it determines whether or not you would proceed with treatment or if you would just continue to follow up with imaging. And the same thing over here. If it's greater than 8 millimeters, normally you determine if it's low malignancy risk versus high malignancy risk, and then proceed from there on the next best steps. So case one, we're going to go back to our 61-year-old male. So his recent CBC with differential showed a low white blood cell count, low red blood cell count, low hemoglobin, low hematocrit, platelets were normal, the neutrophils were normal, his lymphocytes were normal, monocytes elevated, neutrophils, the absolute neutrophils and lymphocytes were both low. All other labs were within normal limits. So as a fourth-year medical student, I was like, wow, this man, he has weight loss, he has a lung nodule. My first instinct was cancer. However, we also know that we have to repeat or compare imaging compare the current imaging to any imaging that we've seen in the past. So after going through his chart, I was able to find some older CT scans for this patient. And it showed that in 2019, the CT showed large cavitary lesion within the right upper lobe / apex with extensive infiltrates. And he also had persistent hilar and mediastinal lymphadenopathy. In 2021, the chest CT showed resolving cavitary lesion within the right upper lobe / apex, improving right pleural effusion. So it finds out the patient was diagnosed with tuberculosis back in 2019. The treatment was provided and the health department was notified. But recently the person came back in complaining of weight loss.
Asia, the chest X-ray in 2021 was, I think that was in March or April, wasn't it?
Yes, in April. Yes. So in April, it seems as if his lesion was resolving. So my big question was, is this a tuberculosis reactivation? So now we're going to get into tuberculosis. My first thought was cancer. After gathering more information, it's potential that this person had tuberculosis reactivation. So tuberculosis that we commonly know as TB most commonly affect the lungs, and the most common bacteria is the Mycobacterium tuberculosis. And here's an image right here of what it looks like under microscope. So there's a you have to determine
is about how you make your workforce
whether or not this patient had active TB versus latent. So let's talk about some of the differences. Latent TB, it means it's quiet. It lives, but it doesn't grow the body. It doesn't make the person have any symptoms. They don't feel sick, and you can't spread it from person to person. However, it can advance to tuberculosis active. It can advance to active tuberculosis at any time. Tuberculosis itself is active. It's grown in the body. The people feel sick, they have symptoms, and it can spread from person to person. If it's not treated, it can also lead to death. So some things to look at if a person has tuberculosis: they may have a cough greater than 2 to 3 weeks duration. They would have lymphadenopathy. They can have fevers, night sweats, hemoptysis, weight loss. They can have some history such as known exposure, especially with a lot of healthcare workers who can also put ourselves at increased risk, and also traveling to endemic areas where tuberculosis lives. What do we do if we're considering a patient that has tuberculosis? And I will reiterate here, tuberculosis screening is different than confirming tuberculosis. Tuberculosis screening is the PPD test that most of us have to do once a year, where you get the injection and you have to come back 48 hours later to read. That's just screening. It's different if you want to confirm whether or not a person has tuberculosis. So some things you can do are getting clinical specimens, a sputum sample, tissue samples, bronchoscopy specimen. Another thing you can do is radiographic imaging. Chest X-ray is usually one of the initial tests used to determine if a patient has a suspected TB. On X-ray, you'll see that a person with primary tuberculosis usually occurs in the upper lobes of the lungs. Tuberculosis loves oxygen, and that's where most of the oxygen is in our lungs. And then some other testing, if you can't get the clinical specimens, you can do an acid fast, bacilli smear. You can also do a mycobacterium blood culture, or you can do some PCR amplification testing. A Gone complex. This is one of the most common signs seen in tuberculosis. It's usually detected more so in primary tuberculosis. And what it's composed of is you have macrophages. They recognize the bacterium, the mycobacterium, and they go and attempt to phagocytize, I'm sorry guys, the bacteria, creating this ball around the specimen. And you can also, this in combination with hilar lymphadenopathy is the Gone complex together.
Aren't they usually cavitated?
Yes, yes,
They get necrosis in the center,
right.
and that's why they cavitate.
Treatment. So here are the treatment options if you're not sure what to do for a patient. Usually test the sputum sample to see if it's resistant to any of these medications before we give the patient the medications. But here's a list of some of them that we typically use. So on the left side, you see the drug-sensitive tuberculosis. You use them for 4 to 6 months, and you usually use 4 of the drugs in this list. The most common ones are isoniazid, rifampin, pyrazinamide, and ethambutol. We call it the RIPE therapy. Those are usually the first ones we go to. However, if there are any resistance in the bug, then we can move over to the second column and choose some of those medications as well. However, the patient usually has to stay on that medication for a lot longer than the ones that are not sensitive, that are sensitive. So here's just the overview of everything that we talked about. Tuberculosis is a disease caused by mycobacterium. It's spread through respiratory droplets, so sneezing, saliva, coughing, singing, me talking, different things like that. There's a spectrum of the disease. You have the active versus the latent, which we discussed previously. And then we can talk about drug options, whether the bug is drug resistant or whether or not it's sensitive. And overall, that's everything I have for you today. And I really appreciate everybody for listening to me.
Well, just a follow-up that we shared this morning, that the Department of Health went to see him.
Oh, yes. So this case is still ongoing right now. We're actually going to see the patient today in the office. And what happened was the health department said that they went out to test him and he tested negative 3 times. However, we're calling them to figure out which test that they used. We're not sure if they did PPD testing or if they did any sputum samples. We're not sure. So we're still following up on this case. And hopefully we can get him the best treatment that he needs.
Can you do a PPD and the person who's got a positive PPD?
No, once your PPD, that's going back to screening. Once your PPD test is positive, it's positive forever. And usually you can have the positive PPD if you've gotten the BCG vaccine or if you've been exposed to the tuberculosis in the past. So normally that's a different process, but if you're a screening are positive, then you would move on to imaging and also some blood testing in that instance as well.
So Azjaah, what are you going to recommend when he comes in today?
Actually, I want to get a little bit more history.
Okay.
Yeah, to see if he's coughing, if he's sneezing. This was back in October. So I'm not sure if he's still having any of these symptoms. But after that, I'm definitely going to go forth with some blood testing today because his X-ray is already proves that he has a lesion and his PPD test is going to be positive anyway. So I would move forward with some blood testing.
Is it worth getting a CT scan or not?
Yes, just to have it on file because we don't have any CTs for him
And you make sure
recently.
he puts his mask on. I would even
Yes.
double mask him.
Yes.
Yeah. What's fascinating about this case was that we had two third-year students, Emily and Amber, that were on a community rotation with us. And they actually were going out in the community, visiting food shelters, homeless shelters. And they met this gentleman in their visit. And they saw he had weight loss, he wasn't feeling well. So they came back, they pulled his chart because he was a patient here, and involved Azjaah at that point as a fourth-year student to get involved. Once Azjaah got involved, then we got Dr. Kinney involved, we got me involved, and we got the health department involved. So it just points out the value of teamwork, starting with a third-year student picking up potentially communicative disease in our community.
Yes.
Well, phenomenal job. I think 6 weeks medical school lectures, you did it in 40 minutes. You didn't miss anything. I think
Thank you so much.
I went to school in a small town